right, welcome back to this afternoon's proceedings. So I'm just about to welcome our first speaker for this afternoon, Dr. Rowena Mobbs, who is a cognitive neurologist, works here at MQ Health some of the time, elsewhere some of the time, expertise in dementia and concussion. And I just found out this really, well, it's not really a random fact. I just didn't really know this about Rowena. Not only is she a legend expert and researcher when it comes to concussion and understanding the effects of concussion, but she's actually a sporting superstar. So Rowena, superstar, totally. Rowena has actually represented Australia in modern pentathlon and fencing, and represented sports at state team level in hockey and triathlon and cross-country running. I just think that is the most coolest neurologist I've ever met. So anyway, I'd like to welcome Dr. Rowena Mobbs.
Thank you so much, Viv. That is the kindest introduction ever. I have to say, this is my Betty. Oh, I'm standing. Hello, everyone. Thank you, and thank you for being here today. Very dedicated. So I absolutely love my sport. I grew up watching footy and all the sports, Wide World of Sports. Do you remember that program? It's great. And so I'm an avid follower. Not so much time to participate. But really lovely to be here today to talk about chronic traumatic encephalopathy, which has sort of hit the scene a bit in this country as far as sports and risks associated with that neurologically. So what I want to do is emphasise that this work places us, I'll just try and, have I got the clicker? No, just click. Next. Oh. Page down, page up. Yeah, I've got the arrows not working. Sorry. Okay. So this is potentially one of the conditions that will impact dementia risk overall for older people. If we think about sport, we often think of younger people, but here the concern is that there may be, even if it's a small percentage of the sporting and non-sporting repetitive head trauma population, the concern is that that's going to be a lot of people in this country. I think there's not just thousands, but tens of thousands of ex-football players who are approaching the 50s, 60s, 70s, which is where we're worried this might start to come on. And in fact, the youngest chronic traumatic encephalopathy case has been 25. If we think back 100 years ago, this is Bondi, circa 1900, and the life expectancy was only 47 for men and 51 for women, be it that they were facing war and famine and infection. So things are definitely very much shifted today, focusing on dementia as the #1 cause of mortality, and how can we reduce our risk? And with that shift in focus away from, although of course we appreciate we must manage heart disease extraordinarily well, but people are living through that now. And patients and families are wanting to understand their dementia risk and what can be done in midlife or even early life, because like all neurological conditions, all illness, potentially the path could develop very early, the change in homeostasis towards disease. But as we get older, of course, into our 70s, we start to creep up on our risk of dementia. And when we're in our 80s, it's approaching a fifth or even a third by the mid-80s and onwards. There are massive social changes in sport as well. So when I grew up, footy wasn't really that much of an option, if at all. But now, of course, we've got the elite levels being infiltrated by women. There's a long way to go for equality, but this is a very welcome shift. And there's, of course, increasing participation through to grassroots. So I think we need to look very closely at the risk of CTE for all types of contact collision sports. This was the concussion incident in State of Origin recently with Boyd Cordner. And so I think the State of Origin series, with so many concussions seen and a debate about protocols of whether to put a patient back on the field, video showing one thing and the assessments for head injury protocol showing another. This just simply highlights that there's a lot more work that needs to be done and possibly a lot more unification across sporting bodies And I would say this may have to involve higher levels like insurance or government to really get anywhere, and possibly code of practice or other means. Here's an example of some of the debate recently in the media. So whilst we fully recognise there's a lot of work to be done, I think there's emerging evidence for not only post-concussion syndrome as a large issue in sport, affecting the impact of a player to play well, affecting their lives and their relationships, but potential chronic traumatic encephalopathy. So what is CTE? What are we talking about? Well, CTE actually is the name for the pathological changes, rather than the in-life correlate, which is termed TESS, or traumatic encephalopathy syndrome. Such a handful to say. my media friends do not like the word encephalopathy, of course, but CTE is the common name for it all. So what we see is a stage 1 to 4 classification. So the early changes are in the subsulcal regions. So they're the depths of the valleys of the brain. And we think that they are more prone to the mechanical effects of oscillations or vibratory effects across the brain with different forces of impact. That could be direct impact, but remember, it might also be whiplash and a shaking effect. It seems that this force might be worse with torsion, where you may get sort of twisting across the brainstem and across the cerebrum as well. And that possibly wearing helmets in NFL might change the centrifugal forces and potentially make those forces worse in the brain. The changes of this tau protein that we see, so which we feel as abnormal, but some people would debate that, spread gradually towards the temporal regions. Eventually there's widespread involvement, and you get, at stage 4, much temporal atrophy, like you would see in Alzheimer's. But the early pattern of the tau staining is reversed to that of Alzheimer's. So Alzheimer's might start a little further south towards the temporal lobe and go up. So I joined the Australian Sports Brain Bank at the start of their work in 3 years ago now. So this was established by Michael Buckland and others, and I think it was a fantastic initiative towards raising awareness around CTE, but also providing that ultimate answer of, do athletes have pathological changes in association with traumatic encephalopathy syndrome? This work continues. I think there's around 15 brains that have been analysed now, but there's much work to go. The Kiwis, as always, are beginning to catch up, if not, maybe overtake us at some stage. So we have to, of course, we'll be working very collaboratively, I'm sure, with our colleagues, because we've got those shared sports, and we need to look, I would say, also to the UK, who also have a love of rugby, league and union, and really look at, are there any differences between those sports and NFL? I'd also highlight the cross interest in horse racing in this country, although of course that extends to the US. And this has become an issue in the media, not only through concern for players and their families, but also the litigious nature of all of this. And I think there's litigation cropping up outside of the US now, so certainly going to be looked at more closely here. And we've demonstrated CTE changes across the football codes now here. In New Zealand, they have a Rugby Smart program encompassing concussion protocols. What needs to be said, however, is that concussion is not the only culprit here, we think, based on the American data, which shows an exposure dependent effect for subconcussion and repeated head trauma risk in association with CTE. And it seems that the younger you play these contact sports, the higher, or the earlier you may present with CTE changes, the higher your risk overall. For every 2.6 years you play, you seem to double your risk as far as NFL. So what is our risk here? No one knows yet. Here's the example of Rodeo, so the heavy whiplash effect from collision with the animal and head impact onto the ground, of course. And the helmet only goes so far. Here's one of my patients, Dale Spriggs. So in Jockeys, I learnt that it is handling the horses well. When they're galloping at, I think it's about 60 kilometres an hour or something like that, the horse head goes into their head potentially, or they might hit the barriers and have repetitive head trauma. It's not just the falling. And once they do fall, and they sustain terrible fractures and internal injuries and may not recognise their concussion symptoms so readily, or at least pay attention to them. CTE in these sports has been identified so far. You'll see their rugby union and rugby league, which I've been involved with at the Sports Brain Bank, but also these other situations. And I think there's some fantastic work in head injury and mixed martial arts here with Rodeo. So hopefully we can look at all circumstances, sporting and non-sporting. Here are some non-sporting examples. So we've got repetitive head trauma in the defence community with, rockets firing, with explosives, of course, with repeated blast trauma. And when I see these patients, I'm talking about 1,000 upwards of blast traumas at a close proximity of 2 to 4 metres potentially. So that, I think, will prove to be a unique cohort, as it has been suggested in the US. Construction industry, so steel falling onto your head or that sort of thing, falls from ladders. Farmers, similar sort of manual labour associated head trauma, but also quad bikes, car accidents, horses, mining industry potentially, and then those who fall. So these are the patients in my clinic who have visual impairment, frailty, epilepsy, alcohol use disorder, or Parkinson's. We must always highlight, of course, domestic violence as a circumstance of repetitive head trauma. And there's an increasing push to provide specific head injury concussion services and post-concussion, but extending to CTE. Identifying that risk in research is really important. And I would say this is forming a bit of a crisis, and we need to look at it very quickly. Our platters are always dangerous, so when you're doing your Bunnings projects, just be careful. How are we testing people? Well, we're examining them neurologically, so we're observing all of their gait. And one of the potential criticisms of this work in CTE is saying that, well, you don't know if it is CTE. Of course, you haven't got a test in life, and it could be other things. It could be depression, could be Alzheimer's, could be Parkinson's, all these things. But the role of the neurologist is to help identify any of those other factors and say so. So we're looking at these patients for their traumatic encephalopathy syndrome. We appear to be excluding other causes. This might be based on neuroimaging, but often the clinical findings in the clinical picture. And one of the highlights of this work is that, or the emphasis of this work is that you cannot provide a certain test for other dementias and be sure of it in life. That includes Alzheimer's, even though we have some better biomarker work these days. But it's no different to other dementia if we're talking about CTE. So we run some screening tests. So I'll very often use the ACE3, Adam Brooks' Australian version for this type of work. Here on the image on the left, you can see as someone who's clearly above baseline, above average perhaps. And so, we'll note that. We're calibrated to on the testing, we assess for that. But then in the middle picture, maybe there's some early visuospatial change. And on the right, you've clearly got visuospatial impairment. So here's an example of observing the writing of someone. And then, of course, we're going to run our MRI. It's a non-radiation, easily available scan. So we're looking for tumours and MS and other things that might mimic the CTE type picture. In future, we'll be no doubt moving to advanced neuroimaging such as tractography to understand this. And this is the work of my sister, Virginia Newcomb in Cambridge, she's looking at all spectrum of head injury and tractography. So the SNAP CTE study, this is admittedly very early work. We haven't yet published on this, but we've got some early pilot data. The aim of this study for CTE, which is comparable to the work that's been done in Boston, and indeed we are collaborative with them, is to look at a large number of participants to really understand the risk of CTE in Australia. Of course, it will take some years before we have those neuropathological correlates, but we surely want to be prepared for that time and have studied them well in life. So it's at least a 5-year study, probably 10. We're looking for funding at Current. We're doing neurology, neuropsychology testing, which we feel is quite sensitive for picking up changes, and we'll be moving to biomarker work. This will be linked with the Sports Brain Bank, as I've said. So far, we've got our early 28 participants, but I've probably seen over 100 cases that could be look towards it for traumatic encephalopathy picture. And our early findings are suggesting difficulties of learning and retention on reduced relative to their predictive levels. So we're looking at their baseline, their IQ, and assessing for any changes there. We're also finding that patients are impaired on insight. So this is one of the key findings if you're looking for a neurodegenerative picture. Of course, you're looking towards decline in the history. You're often hearing a history of short-term memory impairment, but remember, many of these younger patients with test-type picture are managing in the workplace and compensating through their learned memory, but they're having difficulty of encoding and working memory. But the insight is often there, so the loss of insight. So there's a discrepancy between what the carers and loved ones are telling us in clinic as being alarming. So that could be changes in behaviour, such as rage-type episodes, often to the drop of a hat, an underlying baseline irritability that comes and goes and is unpredicted without any epilepsy features, and this difficulty learning, and they have to pick and choose when they tell their loved ones something important so that they can absorb that information, and that gradually worsens, it seems. There appears to be some potential exposure-dependent effect here. So I provide example with my boxing patients who have sustained what seems to be the largest amount of repetitive head trauma, and they appear to have significant global cognitive deficits, plus Parkinsonism and a loss of insight. So this is early work, yet to be peer-reviewed and published, but I would encourage you to watch this space. And if you're interested in working with us and collaborating on this project, we'd be keen to hear from you. So what we can say so far, it seems, is that players show evidence of acquired cognitive impairment. Testing is consistent with the descriptions of cognitive decline from relatives, and players need assistance, whatever the cause. So I'd like to thank the team here at Macquarie, also at the Australian Sports Brain Bank, in particular, Michael Buckland over at RPA. And we're looking forward to seeing where this goes in 2021. So thank you. Any questions? Yep, I will. Okay. Oh, yes? Great. Professor Savage.
Greg to you. Rowena, for the sample you showed us, the 28, what kind of numbers of concussions are we talking about there? I mean, it's probably diffuse. Some will have had frank concussions, some will have just had sub-concussive knocks. Do you get a feel for how bad these people are in terms of what you'd be able to say about them at that level?
Yeah, thank you. So the question is about what sort of level of concussion we're talking about for this early cohort. You know, is that right? What are we talking on average? So our lowest years of exposure, I believe, is 13. Most of them have 20 years exposure or thereabouts. We are talking about people most often in their 50s, going into the early 60s, but 50 seems to be about when we're seeing people presenting with issues. What we're noticing is that concussion has a significant recall bias, we think. So we think people, may not understand what a concussion is, and my definition is very simple. It's any symptoms after a head knock. But that's hard for people to fathom or perhaps admit and understand the potential traumatic brain injury that goes along with that. So we're talking about seeing stars or double vision or confusion to any degree after any head knock. I'm seeing a range of typically about 10 concussions through to more than 1,000, as I say. If we're talking football, the most I've seen is 200 concussions reported by a player, usually across a 20-25 year period. And the other interesting thing is we're seeing that 20 years, it seems to be about the length that people play, no matter when they start. So in this group, so if you start at 15, you're going to 35. If you start at 5, you're going to 25. So whether or not that's having enough of the sport, or whether or not that is some emerging symptoms and impairment and recognition somehow that it may not be a good idea to continue, we don't know. But Of course, we could never measure the burden of subconcussion specifically unless we all wear sensors for every contact in life. But we can estimate it from the years played. We're looking at player positions. We're finding the forwards are tending to report more severe and higher number of concussions, it would seem, although again, yet to be reported. And it seems that if you're a talented player, you tend to get targeted by the opposition, not surprisingly. So there are plenty of examples of top, wingers, for example, really top players who are knocked out quite a bit. And of course, once you sustain a series of concussions, you're more likely to have further. Any other questions? Yes, yes.
So I was just wondering if there are challenges with respect to prevention, because saying the consequences of sports-related concussions are only apparent much later after they happen. So does that mean that the younger players are maybe not bothered about something that may or may not happen many years in the future? And I also wonder if there are any challenges to prevention with the sort of commercial interest that there is in professional sport as well, and maybe may not want to change the game if it makes it less exciting to watch.
Thank you. So 2 very good questions. I'm pleased I'm not the only one puzzling about these, clearly. So the first question was around prevention, I guess. So how do you convince a young player to sort of think about their brain when we don't know what the ramifications are and when they'll occur, if they're going to occur? How do you deal with that and grapple with that? The other thing would be, how are the sports and organisations handling this, and are we sort of getting perhaps a little bit of roadblock, or how are we going to get around that for prevention? So my approach here as a neurologist is towards whole brain health for this very reason. So I think just as we would teach phonics when we're looking at toddlers, I think we should be teaching brain health, and not in a negative way, obviously. We don't want an illness perception. But I think that young minds are very curious, and I would love to at some stage see some sort of public health campaign around looking after your brain in life. And I think that'll lower risk, whatever the cause, and we'll get to a better place as far as CTE. In the States, there's been a shift towards no tackle until age 14 and beyond, which does seem to be common sense to me. That's based on their data of exposure and risk to repetitive head trauma and risk of CTE. We're not there yet, as I say, but I think part of the answer will be involving athletes and families at the decision table on protocols in sport. No doubt there will be rule changes or other ways we can look at modifying concussion risk, so frank head trauma. How on earth we tackle when you give up and what the outlook is when you've had too many head knocks, I don't know. And I take a little bit of a approach of, well, it may be up to the individual themselves, but we need to guide them and help them be aware of their sort of risk over all of these potential consequences. Not everyone will get CTE for the same head exposure, of course, so we've got to look at factors of genetics and other that might modify their risk. So there are a lot of challenges going forward, but I think that there no doubt will be ways to lower the risk of concussion and lower the risk of head trauma in sport overall, or at least I hope there will be, without impacting necessarily participation in sport. And of course, that's one of the critical things going forward, to really encourage sporting participation. But parents are going to want to know that it's reasonable and that we're aware of what risk there could be so that they can navigate those risks. Yeah. Viv?
I was just kind of interested in that link, that we talk about between concussion and dementia risk down the track. And so I'm wondering, does it matter what age these concussions happen in terms, is there some kind of recovery, if the concussion's in childhood is less problematic than if it's later in life, or,
Yeah, so the question is about concussion severity and age. So we have fairly solid research to suggest that children experience a more severe and more prolonged concussion state. There's some really interesting work emerging out of Westmead, I think, to look at how do we test really young patients and understand, do they have a concussion, how to extract symptoms and signs and determine that. It would seem that the young brain is vulnerable overall. We need to err, I think, on the side of more time for rest of the brain, especially as we don't understand whether, well, in fact, the building evidence is that symptom resolution doesn't necessarily mean that the brain is back to normal. So I would think there needs to be an arbitrary extra time once someone is asymptomatic away from contact collision environments. But of course, we don't want to ruin the whole season necessarily. We do have evidence that having one concussion makes you more vulnerable to further concussion, at least within a fairly short time frame, over weeks or months. And that may be ongoing inflammation in the brain, but it also might be poor judgment of where you place your head in relation to players and sustaining a concussion further to that. So it's all a little bit grey at current, but I'd be erring on the side of more time away from sport for my family if I was looking at that issue. Thank you. I think that's all the questions. Thank you very much.